Bundle branch blocks and hemiblocks. Take-home points. Bundle branch blocks are best characterized on ECG by prolongation of the QRS greater than 0.12 seconds. Region of slowed conduction determines the orientation of the terminal QRS vector and localizes the block. Hemiblocks do not typically show QRS prolongation, rather they reveal axis deviation corresponding to the QRS terminal vector. Ventricular conduction blocks are common and can represent a spectrum from normal variant to serious pathology. Normal anatomy of the cardiac conduction system. Synode. Avenue node. Bundle of His. Left and R bundle branches. Septal fascicle. LOF. LPF. Purkinje fibers. Myocardium. www.nottingham.ac.uk/cardiac_conduction.gif. Anatomy of the ventricular His Purkinje conduction system. Left bundle branch. Right bundle branch. Left anterior fascicle. Septal fascicle. Left posterior fascicle. Bundle branch blocks. Intrinsic impairment of conduction in the left or right bundle branches. Can be chronic or intermittent. Can be rate dependent. Can be present without cardiac disease. Most often due to CAD or HTN causing ischemic or degenerative changes, EKG manifestations of BBBs. Widened QRS complex greater than 0.12 seconds. Results from slow myocyte to myocyte conduction causing prolonged ventricular depolarization? Incomplete, 0.8 to 0.11 s, or complete, greater than 0.12 s. Terminal QRS is sluggish and reflects the electric forces in the affected ventricle. LBBB equals terminal QRS is superior, posterior, and left. RBBB equals terminal QRS in inferior, anterior, and right. Repolarization abnormalities. ST and T wave oriented opposite of the terminal QRS. Right bundle branch block. Left bundle branch. Right bundle branch. Left anterior fascicle. Septal fascicle. Left posterior fascicle. Phase 1. Initial QRS in RBBB. The initial QRS deflection represents the septum depolarizing from left to right. This conduction is mediated by the septal fascicle arising from the left bundle branch. The initial QRS is unchanged in RBBB because conduction is independent of the right bundle branch. Phase 2, RBBB. Following the initial QRS, the left ventricle rapidly depolarizes via conduction from the LOF and LPF. The right ventricle is delayed. This produces a QRS vector oriented to the left and posterior. The left ventricle is normally dominant during the QRS and thus the EKG still shows no abnormality. Phase 3, terminal QRS in RBBB. Following left ventricular depolarization, there continues to be delayed depolarization of the right ventricle via slow myocyte to myocyte spread. The right ventricle is now the dominant electrical force and therefore the terminal QRS vector is oriented to the right and anterior. This shows on an ECG as an additional tall upright R wave in V1 and a deep S wave in V6. RBBB initial QRS remains normal, middle portion of QRS remains normal. Terminal QRS is sluggish and dominated by right ventricular forces. ECG findings in RBBB QRS duration greater than 0.12 seconds RSR pattern in V1, V2. R is recorded in the right recorder leads demonstrating the period of RV electrical dominance. Wide S wave in leads I, V5, V6. Reflects slow RV conduction oriented towards the right and anterior. This is the left lateral lead equivalent finding of the RSR in the right lateral leads. Normal axis of initial 0.06 to 0.08 seconds of QRS. QRS, or RS in I, V6, RSR or QR in V1, reflects anterior mid-temporal right ventricular enlargement and left anterior fascicular block. Secondary ST wave changes. ST depression and T inversion in right precordial leads, upright in left precordial and limb leads. STT vectors are discordant to terminal mean QRS spatial vector. Right bundle branch block. Notice the wide RSR complex in lead V1 and the QRS complex in lead V6. Inverted T waves in the right precordial leads, in this case V1 to V3, are common with right bundle branch block and are called secondary T wave inversions, RBBB. RBBB incidence increases with age, can occur as a normal variant. Most common cause is CAD, LAD. Other causes include both structural and functional causes. Structural, anything causing RV dilatation or hypertrophy, acute P, cor pulmonale, DCM, ECT, trauma, right heart cath, steering wheel, CABG, ablation. Functional, rate-related bundle branch block, differential diagnosis of RBBB. Myocardial infarction. Pulmonary embolism. Chronic obstructive lung disease / cor pulmonale. Pulmonary hypertension, primary or secondary. Hypertensive heart disease. Degenerative disease of the conduction system. Brugada syndrome. Arrhythmogenic RV dysplasia. Cardiomyopathy. Chagas disease. Congenital heart disease, e.g., Epstein anomaly. RBBB, prognosis and treatment. Prognosis depends on underlying etiology. Worse prognosis for patients with type 2 second-degree atrioventricular, avenue, block or multifascicular block. Generally good prognosis for patients without underlying heart disease. No treatment necessary for isolated asymptomatic RBBB. Pacing may be necessary for symptomatic patients or those with other avenue or multifascicular block, RBBB and ME. T-wave inversions may be seen in leads V1, V3, 2, 3, and AVF secondary to the additional RSR type complex, changes to QRS axis. ST and T wave changes in the same direction as the terminal QRS complex should be considered primary abnormalities, ventricular gradient not between 0 degrees and 90 degrees in the frontal plane. Since RBBB does not alter initial phase of ventricular depolarization, RBBB does not mask abnormal Q waves seen in ME. Left bundle branch block. Right bundle branch. Left anterior fascicle. Septal fascicle. Left posterior fascicle. Phase 1, initial QRS in LBBB. Normally the LBB begins the initial QRS with left to right septal depolarization. In LBBB the first phase is altered. The initial QRS vector remains slightly anterior and oriented right to left. Phase 2, LBBB. The right ventricle is stimulated first via the intact RBB while the left ventricle proceeds by slow cell-to-cell depolarization. The RV is not seen on ECG since it is overwhelmed by larger forces from the LV. This slow depolarization through the LV creates a widened QRS complex with upward deflections in the lateral leads. In LBBB all phases of ventricular depolarization are affected. LBBB initial QRS orientation is right to left. Middle and terminal QRS forces are dominated by the larger left ventricular forces. Slow conduction causes long QRS deflection. ECG findings in LBBB QRS duration 0.12 seconds intrinsicoid deflection. Greater than 0.05 seconds in lead V6. Common pattern. Loss of Q wave and wide slurred monophasic R in I, AVL, and V6. RS or QS in V1. ST depression and T wave inversion in leftward leads. ST elevation and upright T waves in right precordial leads. These changes reflect relentlessly leftward vectorial forces. V1 morphology depends on initial leftward or rarely rightward forces. ST and T vectors are usually 180 degrees discordant to the QRS vector. Variant pattern. Terminal S wave in V6 but not usually in I. Mean electrical axis superior and to the left, about -55 degrees. ST depression and T wave inversion in leftward leads, ST elevation and upright T waves in right precordial leads. These changes reflect superior and posterior displacement of loop with a terminal, often rightward, conduction delay. ST and T vectors are discordant to the QRS vector. LBBB. 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 LBBB and ME. T waves in leads with tall R waves, left precordial leads, are inverted secondary to changes in QRS in LBBB. T wave inversions in the right precordial leads cannot be explained by LBBB. ME can be difficult to diagnose on ECG in LBBB because Q waves/ST elevations can be masked. Exercise stress testing is of limited value in CAD. The 2002 American College of Cardiology/American Heart Association, ACC/AHA, guidelines concluded that there is no level of ST segment depression that confers diagnostic significance during exercise ECG testing in patients with LBBB. Can use myocardial perfusion imaging, IPI. LBBB incidence increases with age. Almost always associated with underlying heart disease. Most common causes include CAD, HTN, dilated CM, hypertrophy/dilatation of LV. Other causes include valvular diseases, rheumatic heart disease, aortic stenosis, ECT. Rarely results from primary degeneration of the conduction system. Rate or acceleration dependent LBBB. LBBB prognosis and treatment also depends on underlying cardiac conditions. Worse prognosis for patients with type 2 second-degree atrioventricular, avenue, block or multifascicular block. Prognosis depends on age, worse with increasing age. Isolated LBBB is more likely than RBBB to progress to high-degree avenue block and has worse mortality. No treatment for asymptomatic isolated LBBB is necessary. Pacing may be necessary for symptomatic patients or those with other avenue or multifascicular block. Hemiblock, fascicular block. The left bundle branch divides into three separate fascicles. Septal fascicle innervates the ventricular septum. The anterior fascicle runs toward the anterolateral papillary muscle and projects anterior, leftward, and superior. The posterior fascicle runs toward the posterior papillary muscle and projects posterior, rightward, and inferiorly. Normal electrical activation of the LV spreads simultaneously from the base of the two papillary muscles. LBB, RBB, LOF, SF, LPF. Hemiblock, fascicular block count. A fascicular block occurs when you have impaired conduction down one division of the LBB. The block is manifested on EKG as QRS axis deviation. No, minimal QRS prolongation, 0.09 to 0.11 seconds. Most commonly due to CAD and ME, also cardiomyopathies. Left anterior fascicular block. With LAF, the LPF carries the initial depolarization inferior, posterior and to the right. Then the vector shifts unopposed to the left, anterior, and superior. Common cause of left axis deviation. LBB, RBB, LAF, LPF, LAF, ECG findings QRS duration less than 0.1 seconds. Left axis deviation, usually -45 degrees to -90 degrees. No other identified cause of left axis deviation. Tall R waves in I and AVL. Big S waves in 2, 3, and AVF. LAF. QRS has normal duration. Left axis deviation. LAF QRS has normal duration left axis deviation. Tall R waves in I and AVL. Deep S waves in 2, 3, and AVF. http://images/cd/laf.jpg/750px/lab.jpg. Left posterior fascicular block. With LPFP, the LAF carries the depolarization left, anterior and superior. Then the vector shifts unopposed inferior, posterior, and to the right. Rare cause of right axis deviation. LPFP is less likely to be caused by ischemia because it receives dual blood supply from RCA and LAD. LBB, RBB, LAF, LPF. LPFB, ECG findings normal duration of QRS less than 0.1 seconds. Right axis deviation, +90 degrees to +180 degrees. No other identified cause of right axis deviation. Big S waves in I and AVL. Big R waves in 2, 3, and AVF. LPFB. Bifascicular blocks, RBBB and LAF. QRS greater than 0.12 s. RSR in V1. Wide and slurred S waves in I, V5, V6. First half, 0.06 s, of QRS having frontal plane axis of -30 degrees to -90 degrees. Initial R wave in inferior leads. Bifascicular blocks, RBBB and LPFB. QRS greater than 0.12 s. RSR in V1 with R broad and slurred. Wide and slurred S waves in I, V5, V6. First half, 0.06 s, of QRS having frontal plane axis of +90 degrees or further to the right with RS deflection in lead I and QR waves in 2, 3, and AVF. Unknown. QRS prolonged more than 0.12 seconds. Terminal forces are left and posterior. DX, LBBB. http://sineom.org/wp-content/upload/2007/LBBB_EKG1.jpg. Unknown. QRS prolongation greater than 0.12 seconds. RSR in V1, V2. Street, T-wave abnormalities. Slurred terminal S wave in I, V3, V4, V5, V6. DX, RBBB. www.sphamresidency.com/assets/images EKG_2 to 13. Unknown. QRS has normal duration. Right axis deviation. DX, LAF. Unknown. QRS prolongation greater than 0.12 seconds RSR in V1, V2, V3. Street, T-wave abnormalities. Slurred terminal S-wave in I, AVL, V4, V5, V6. DX, RBBB. askdwiki.com/media/images/b/bb/rbb.png. Unknown? QRS prolonged more than 0.12 seconds. Terminal forces are left and posterior. DX, LBBB. http://www.ncb.nlm.nih.gov/bookshelf/br.fcg. Book equals cardio and part equals 839. Unknown? QRS has normal duration left axis deviation dx, LAFB. http://wiki.com/mediawiki/images/thumb/c/cd/lafb.jpg/750pxlaub.jpg